So good afternoon. Today's meeting of the HHC Accountable Care Organization Sole Member Annual Meeting for calendar year 2022 is now called to order. So for the record, please know that Dr. William Fisher is representing Deepa Abula. And thank you for being here. And Karen San Hilaire is representing Molly Wasson Park, both in a voting capacity. So next on the agenda is the adoption of the minutes of the HHC ACO annual membership meeting held on December 16th, 2021. Are there any questions, comments, or changes to the minutes? So may I have a motion? Sure. Let me then ask for your vote separately. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Fisher?
Yes.
Dr. Martone? San Hilaire?
Yes.
Dr. Peñamora?
Yes.
Hernández Piñero? Yes. I don't see Anita Caballo, Jackie Rowe, and Jose Pagan, yes. So minutes approved. So next on the agenda is a resolution for the annual election of the officers of the ACO. Mr. Ziegler, please, you want to read that resolution?
Absolutely. Thank you. Authorizing that each of the following persons be elected, effective immediately, to serve as a director of the HHC HHC ACO Inc., the ACO Board of Directors, in accordance with the laws of the state of New York. On the slide in the presentation, you see the individuals. The only change from prior year is the Physicians Affiliate Group of New York line is vacant as they continue to search for a permanent CEO. But we work closely with their CFO and others in that. All the other board members have remained the same from last year.
Okay, so let me then call for the vote. All in favor, please say yes.
Yes. Yes.
Both say no. So the resolution is approved. Thank you so much, Matt. So you want to go now and provide an update on the activities of the ACO? Mr. Ziegler, Dr. Stevens.
Great to be here. I'm Matt Ziegler. You all know me. One of my jobs is the CEO of the ACO. Good to be with you. Dr. David Stevens is the Chief Medical Officer of the ACO and our operational leader of the team day to day, and also the ambulatory care chief at Kings County. So we're going to talk about our performance and update you on the ACO this year. A year ago, we were here talking about our performance and what we thought the future looked like for the ACO, and it looked quite different. We were in our first year coming out of COVID on the performance, and costs and utilization had crept back up in a rapid way, and the scale of risk adjustment and other opportunities that were available to us, we weren't sure if they were going to be able to produce shared savings for us again. We'd had 8 straight years of shared savings, a nearly unmatched record around the entire country, and with the change and disruption of that of the pandemic and other things, we weren't sure how we were faring, but we have learned a lot, and we did in fact achieve shared savings for the 9th year in a row. It has now been almost $40 million of earned performance payments for our providers and our partners, and $72 million worth of savings to the Medicare program over the late.
I need to clap on this because it's just pretty impressive. And I wanted to ask you, can you put it in context in terms of how other ACOs are doing? Or?
I believe that there are less than 10 in the entire country that have had this level of shared savings, this consistency. The team could check me on that, but I think that's where we are. And I believe we're one of, if not the only, in New York State that has done this throughout. So it's a tremendous accomplishment given all the disruption we had. And I think, the basic story is that while costs and utilization for Medicare beneficiaries certainly went up in the period immediately following the pandemic, health and hospitals, as it often has with our partners here, they went up much more slowly with us than they did with others in the region. And so that was the major driver of our shared savings compared to prior years, and made it difficult to project. So the reason we came forward warning about the future of our shared savings was our inability to project those very dynamic regional trends. But we were really pleased to see that our cost growth remains slower than others in the region and is a testament to the mission and focus of our providers and our teams, and the great clinical quality work that we do to improve the care for these beneficiaries. So we have the details in here, and you see how the projections adjusted throughout the quarters last year. But at the end of the day, we did have another year of shared savings and an earned performance payment of around $4 million that we will shortly be distributing to our providers and our care teams around the system.
Matthew Faniaski has a
Yes,
question.
sir.
Thank you, Matt. It's always very impressive, even though you are having many hats. So it's also another feat. I just have a question of the prior slide. Can you elaborate a little bit why the University Physicians of Brooklyn and the SUNY Health Science Center of Brooklyn
Yes.
kind of is no longer participating? Is there anything that of significance there?
Sure. I'm sorry to skip that slide. They're a relatively small participant. They were about 300 members in the ACO. They are partnering up with a different ACO in the region who they have clinical relationships with through SUNY generally. I believe, I don't know if it's public. I believe it's another hospital in Brooklyn, Maimonides, who has an ACO that they work with. They were good partners throughout. I think we have a good relationship. But I think that is a relationship that they're building in other ways, and they felt it was the right move for them here. But again, 300 out of 8,000 or 9,000 beneficiaries in the whole thing, so not terribly material to our operations.
Will they share in the savings of that you just reported, or they will not be part of that?
They will, because this change is effective for 2023.
Okay.
So they will share in this shared savings, and I believe if we have them for next year, because this is a change officially for 2023. But we wanted you to know what is coming forward.
Thank you for sharing that.
Yes, sir.
Yeah, so I know in the past we've had those discussions about the distributions and how to do the distributions to hopefully continue to encourage good behavior and people who have done exceptionally well. I know that's always a struggle, particularly in a situation like ours. So just curious, how has that all sort of been worked out to try to make sure we are sort of incentivizing, again, good behavior, hopefully good utilization with excellent outcomes, which is,
Right.
of course, the ideal group.
Yes, no, I think we've had a very consistent distribution methodology for the 3 years that I've been helping lead the ACO. I think it is a balance between consistency across all of our providers, because everybody is working very hard and dedicating their time to these patients, but with a meaningful adjustment based on quality performance at the facility level. There is not as much focus on kind of individual provider level quality, because the sample size is relatively small, right? We have 400,000 unique patients across health and hospitals that see our primary care doctors and others, and this is a less than 10,000 population. So large adjustments based on individual physician level, the patient satisfaction for one instance, could be very, very small sample sizes. So I think we've erred on the side of consistency and fairness and encouraging this behavior, rather than major differentiation between physicians just because of the size of the sample. The other thing that you may recall from a few years ago, as we moved into this potentially more rewarding but slightly more risky track 3, we have been putting away reserve funds to protect ourselves in a downside scenario. Those continue to accrue, and we are being responsible with those. But luckily, the distributions in the last 3 years have been 2 of the 3 years have been the 2 largest in the history of the ACO, particularly last year's. And so I think there has not been people have understood the importance of reserves, and there's still been healthy distributions at the physician and care team level. So I think it's going smoothly. We will have our next board meeting with the participants shortly after this one. But I don't expect any changes or issues on that front. Okay, so we'll give just a quick update on how we're trending for performance year 2022, and then we have a a discussion on how our clinical quality is working and some of the focus of how the ACO is helping lead and break new ground on our value-based payment work around the whole system. So because of our experience last year, what we learned about some of the regional adjustment factors and how we're monitoring our performance this year, we do think we will be able to earn shared savings again. Our costs are rising with inflation and other things, but we are below the benchmark spending, and it looks like we will be eligible for shared savings by the end of the year. Again, it is a window within which you of certain shared savings or loss that you do not either owe money back or earn money. We think we are outside of that window and we'll be able to deliver shared savings. The public health emergency is still in effect for the performance year of 2022. So we, even in the worst case scenario, we don't think we would owe money to CMS. So it should be another solid year of performance there. And then Dr. Stevens, I could turn over to you to talk about our quality performance.
Sure, we have mostly good news in the quality measures. We did earn all our eligible shared savings by meeting the quality benchmarks. Our final score was hair shy of 80, and the benchmark was 61.7, so fair cushion there. Our strongest performance was in the chronic disease measures and the prevention measures, specifically diabetes control, hypertension control, and depression screening and follow-up, and in all those we did quite well. That's not surprising. We've been focusing on that for quite some time. In the CAPS, which is the patient satisfaction measured by Press Ganey, we survey the ACO members separately, then we measure the rest of our population, but the scores align pretty closely with what our system sees. And our score is for 21 is 89. And we are doing, we met the threshold there, just to be fair, that that metric is getting tougher. The threshold to meet shared savings and that is going to be tougher as we move forward. Areas we need improvement on, and these are areas that help both meet our quality benchmarks as well as our shared savings, have to do with admissions. 30-day all-cause readmission rates, all-cause unplanned admission rates for patients with multiple chronic conditions. So these are chronically, both groups are basically chronically ill patients. And how do we reduce their admissions? While we didn't meet the benchmark for these, rolling it up into the full composite score, we met the composite benchmark, but not for those. And so in a little bit, I'll talk about what we hope to do about that.
David, I don't know if it's more appropriate now or when you're talking more about it, but what's been interesting to me is that the academic research on reducing readmission rates, even with pretty expensive, complicated interventions, has generally not reduced admission rates. Right there. I mean, multiple people have tried a variety of different interventions. And generally, when you randomize them, no difference, which suggests that it's the underlying need of the population for readmission. And so, I mean, it's a good thing to avoid, but it may be that no one has figured out a way that does it without. I mean, sometimes people really need to be readmitted, right? And sometimes they left at the right moment and they really need to come back. But I think it's interesting that in general, when they've done the real rigorous randomized interventions, no difference so far.
I agree. The well-funded studies in academic settings get about a 5% relative improvement. It's 5% to 15% is not a couple of points. It's not a big difference. When we look at the individual populations that seem to be driving the readmission rates, what we are looking at as quality, and are they getting all the right steps of care? If they have heart failure, are they getting discharged on the right medicines? Are they getting appropriate soon follow-up? Are they being tracked as a high-risk patient? So I think we have room to optimize the care. Whether that translates into a dent in this number,
you're doing the right thing, whether it changes the readmission or not. So
by all means, that's great that you're doing it.
One of the areas that, as you said, there's not a lot of good evidence about programs that really do have some impact on improvement, but one area that seems to be is that ability to get the patient quickly back to medical provider, primary care, maybe more appropriately, a cardiologist or whatever, in a CHF, or how are we doing with that? How do we deal with discharge from hospital, particularly will be super utilizers that are frequent readmitters, because I'm sure they, you know who they are, basically. How are we doing with making sure they do get back to the?
We've found that we don't do that as reliably as we should. And part of that comes from access problems. Part of that comes from, not building out access for that. Because if, routine patient next available 3 weeks might be okay, but if that person's coming out of the hospital, that 3-week slot is too far out. Some of our facilities are doing well with this, and those that have done well with it have built pathways. They have heart failure nurse practitioner that will connect with that patient on day one, and then in person, or they've carved out. Again, there's a lot of different ways to do that, but one way or another, a clinician having a real connection with that patient, understanding, are they getting better, are they getting worse, are they doing the right things or not? We find that there's a lot of gaps. Our patients are complicated and they have complicated lives, and a lot of them just don't even get the medicines they're discharged on. And it's not for lack of trying. So that's clearly an area to target, connecting people quickly to someone who can make sure they're able to take care of themselves.
How much do we use for that, the new tools in Epic? I know that, I have been a couple of meetings in which they're talking that Epic is trying to go more onto that follow-up. Is there any particular element that has proven to be helpful on that follow-up and helping the patients to be more on track, or not really?
Are you talking about sort of something that's automated that Epic generates?
Yeah, and like helping follow up, like checking you taking the medicine and kind of helping them like kind of arrange for the follow up with the physicians or the specialists and things of that nature.
So we've built a powerful platform for that called Compass Rose as part of Epic to support that care coordination piece. And we're really just now putting it to work. But it's got to be, it's just got to be standard. Like you shouldn't have to say, oh, I have to remember to call that person. It needs to be programmed into Epic so that we know exactly who needs to be seen. So that is work that needs to be done.
I would say Compass Rose is the platform that our community health workers document in, right? And that workforce is a critical part of this. And then other features like self-scheduling through MyChart, which is an expanding feature. That is another avenue that we hope can get people in more quickly as we continue to standardize templates, visit types, and rolling slot access to open up visits more quickly through the call center and other places. But the MyChart scheduling and Compass Rose are certainly two Epic features that are helpful here and in use and growing.
Thank you.
Any other questions on this slide? So the next slide sort of picks up the same metrics, but again, just highlighting where we're pretty confident, the chronic disease metrics, which are the way, and then are transitioning towards all payers, not just how the ACO members are doing with diabetes and hypertension and depression, but all our patients. So thankfully, H&H has a solid registry to track those metrics, and we do well. That yellow, again, is that patient satisfaction, both on the access side and provider satisfaction. We actually do what most people would think is pretty good when you look at patient satisfaction. It's just the bar is so high. 90% of our patients giving us the top score is not good enough. It has to be 95%. So we've started looking at that data and what drives patient satisfaction, and we're working with the ambulatory care counsel to look at specific interventions to move that in the right direction. And then we've already started the conversation about admissions and readmissions, which is,
Okay. In that area of the satisfaction, that kind of raising the bar, is that because it's a kind of a competitive nature of how other hospitals are doing? Or is there is a threshold that the government has set up? Why is that high, you know?
why are patients at other systems more likely to give their providers the top rating more reliably than they do, better than 9 out of 10 times,
Mhm.
is the question. I don't have a specific answer for that. I can say that in New York State, it's a cohort effect. The all New York State institutions do relatively worse in that top box, that top rating for their providers. New Yorkers just seem to be a tough crowd, apparently.
Okay. Thank you.
Just with respect to the good news, which is how well we're doing with these chronic diseases, any specific programs that are actually run out of the ACO specifically for things like making sure the AMCs are done and making certain that.
Yeah, so that's really a body of work that's driven by our population health office. And that's work that's been going on for 10 years. There are pathways for patients with uncontrolled hypertension, the treat to target pathway. And in recent years, the introduction of clinical pharmacists has really driven the diabetes control. All the ACO is doing is pointing out patients that might need more help, but we're not introducing any clinical intervention.
With the clinical pharmacists, they work via the ACO basically, or no?
They're in primary care at all the facilities.
Okay, so it's.
They've become part of the patient-centered medical homes. So primary care drives the vast majority of diabetes care, and the pharmacists have both better access so they can see patients on a weekly basis, and also an enormous facility with all the new medications have really been started to drive that even better than where we're going.
Best to remember that, for example, I have many patients with diabetes, many patients with hypertension. I have access to those interventions, but I have no idea who's in the ACO. Right. And I think that's good. Right. We don't want anybody, focusing just on the ACO people. But so my patients are getting those interventions of the pharmacist and the treat to target by the nurses. Some of them are probably in the ACO, but I have no idea which ones, and everybody is getting that intervention.
And from an ACO metric perspective, that's fortunate because the metric is shifting away from looking at diabetes in the ACO population to diabetes in our entire population, all payers. So we're prepared for that. Any other questions on this? Okay. So the next slide sort of encapsulates the work we're trying to do to optimize the care for a group of target populations that are more likely to go to the emergency room, more likely to be admitted, more likely to have multiple admissions. And as Dr. Katz mentioned, we're not trying to reduce them directly. We're trying to improve the care so that hopefully if the care is optimized, we will reduce admissions, but this is a very complicated population, and they don't always get admitted for the reason we expect. So the 5 groups that we're focusing on congestive heart failure, which is the single biggest driver of readmissions. Frail elderly, which is not captured in a specific diagnosis, that no one's admitted because they're frail elderly, but it's underlying much of our longer admissions, our nursing home admissions, and so that's a group that we really want to focus on. We've been focusing on for a couple of years. We'll continue that. Historical high utilizers, if you were admitted twice last year, good chance you'll be admitted a couple of times this year. Making sure our primary care teams, our community health workers know about these patients and see what we can do. Is there some element of their care that can be improved to keep them at home. Asthma is a group of patients more likely to use the emergency room than get admitted these days, but we're working on that as well. And end-stage renal disease. These are the 5 groups that add up to a significant subset of the admissions. So the next page.
Question before we go to the next page. I noticed that people with chronic psychiatric problems are not one of the key populations. I would think they would drive to some extent both medical and psychiatric admissions. I don't know if psychiatric admissions are included in the metric scale, but I guess you're finding that they're not a major driver of the admission.
Yeah, no, you are correct. They are a major driver. It's a small number of patients with a very high utilization. For that, our behavioral health office has focused on those patients. We do want to learn more about them and are there interactions between the medical illness and the psychiatric illness. Because when they coexist, when there's a social problem, a psychiatric problem, substance abuse problem, that plus a significant chronic illness, those are the patients that get admitted.
Thank you.
Question. Hi, yes. You mentioned home admissions. How does that work? And do you you're following up on the patients when they leave the hospital?
Right. So if the nursing home patients, if they go for subacute rehab, they're still on our roster. They remain on our roster. They come out in 2 weeks, 3 weeks, 6 weeks. They remain on our roster. We've started alerting the primary care teams who are the patients that are getting these admissions so that they can reach out to them while they're still in subacute rehab, because they're coming home again.
Right.
And we are not collaborating with the long-term care per se at this point. We're really working through the primary care teams so they're prepared to take them when they get discharged. Answer the question?
Yes.
We do also work with our home care division at Health and Hospitals.
Okay, so that's okay. So
To go into people's
So they have the
homes.
home care to actually go out. This is what I'm okay.
Yes, so we have that as well. But what we see as one of the major drivers of these expenses are the subacute rehab, kind of quick nursing home visits that repeat throughout a year. So that's what Dr. Stevens was talking about. But certainly home care is a key part of it as well. and
Thank
they're
you.
Good
Okay.
partners of ours. I would just say this slide is an important thing for me to highlight what the ACO can do and what it maybe could do, but where we focus it, right? It is a small but mighty team, and it's a small membership, but it's a visible one, an important one to try things out for the system and to see where we can make a difference that can then spread around the whole system. So a couple examples just from what we've already gone through. Very high patient satisfaction scores in the ACO. Those are our most difficult measures in our managed care value-based payment. So some of that is the Medicare population versus a much more Medicaid population, but there are certain things that highly engaged primary care doctors who work with the ACO and are engaged with us get slightly better scores. Are there best practices we can spread across our other primary care doctors who aren't as focused on ACO patients? Another one I'd highlight is asthma, right? So major issue around the whole system. These new guidelines, training, order set, and CHW workflows. This is not a 6-person ACO team rolling this out and implementing it in every facility, in every emergency room, 24 hours a day, 7 days a week. But they did really help draft the guidelines, start the order set process, drive this forward. And so it's an example of a small team spotting a key clinical issue, working with stakeholders in many, many departments throughout the entire system. And now it's going to roll out and be a new protocol for the entire system for every patient we have. So, that's how we try to use the ACO, to look for pockets of success, pockets of things that we see maybe in our population that can then be spread, and try to implement it around the system. So I just thought I'd highlight that as what we try to do.
Is that, by the way, asthma slash COPD, or is that specifically?
The guidelines are focused on asthma. The guidelines have basically, in a nutshell, moved to be much more aggressive on the controller medicine. In the past, controller medicines were not given to people with quote unquote milder asthma. But the evidence shows that you can keep people out of the emergency room more by putting the controller medicines up earlier. And our managed care data actually shows very clearly there's room for improvement in that. So updating these guidelines, we've also introduced trainings and patient education materials widely so that our nurses can get involved in this as well. COPD, we have a community health worker program for asthma that includes COPD, but the specific guidelines are not for COPD.
For ACO members, like when they get discharged from the hospital, do they have a community health worker assigned to them? All of them, some of them, or how does that work?
Again, remember, we don't know who's a
Well, I
ACO
mean-
member.
Well, okay, for any patient in our patient population, how about that?
Some do, right? It's depending on their risk and some of their other medical history, their connection to our practices already. So it's certainly not a universal for every ACO member. We do send Dr. Katz alerts on his ACO patients when they're admitted, and all of our, but and every other primary care doctor. We don't just do it for Dr. Katz. But
I guess none of my patients have been admitted.
you're a very good primary care
Thank you for
doctor.
that.
Yeah.
Right.
So.
Never readmitted.
But so it's not universal for every admission for an ACO member, but it is based on, their weighted risk and other factors.
So one thing that I have no way of testing this except going through a clinical trial, like the way Dr. Katz would prefer,
Mhm.
but or would do. But I always think that many of the patients that we deal with and many of the health conditions that you have there, like a lot of it is like almost like I call it hand holding, which is basically having someone that owns the patient when they get discharged and follows through, that speaks their language, does all these things, and it's just something worth thinking about. I think that.
So I'll come to that second statement first, but in terms of how they get connected,
Yeah.
Every time somebody from the ACO who passes a risk threshold is discharged, we're sending that list out to the primary care teams, asking them to review them. And our guideline says most of these patients should be referred to the community health worker. And we didn't want to say all, but we also want the primary care provider to be the one engaging the community health worker, because that's a very powerful
Yeah.
dyad. The patients will accept it more if they say, oh, my doctor asked me to.
So what I'm suggesting is that the community health worker, in a way, is the only person that really owns the case, in a way. And then they're the ones who, if the doctor doesn't follow up, they're the ones like do that. But if the person says, I'm going to go to the ED, they're the ones that tell, hey, wait a second, we need to call. Because a lot of it is like, in many cases, folks don't know what to do. I like to have someone that tells me what to do. And I think in a way, patients are the same way, because it's complex, right? But anyway, I was wondering about it because you have data, right, on people that you're serving with community health workers, some that don't. And I'll bet you that if you look at it some way, you may be able to see some interesting.
Right, it'd be hard to compare because
Those-
so many of them have been getting the community health worker.
Yeah.
And I could not agree with you more. I think it's actually getting more complex, right? So even heart failure, every patient with heart failure has to be on 5 medications. As the treatments get more and more complex, we risk losing our patients in their ability to self-manage. So they do need that hand-holding. So I completely agree with you.
We did something like this with postpartum care several years back in a project that I was in, and the results were pretty impressive between patients that spoke one language and then the community health worker that spoke the same language. And I was like, I couldn't believe it. And a lot of it was basically facilitating processes. We're trying to increase the rate of women that would go to the postpartum care visit to meet a metric, quality metric. But anyway, thank you. And there are more questions.
Just following up on this, and again, when you were talking, Jose, no, the word concierge was coming to my
Concierge.
mind because, like usually that's what happens is that they address and solve the problem and connect you with the hard to get tickets, I guess. But, one population, I know we had discussed in the past that particularly for certain groups here, is this whole home attendant community because a lot of those patients may have home attendant partially or full time. I don't understand. How much are we working on bringing that network together with the community health workers? Because these are the individuals that are there. We visit the person usually every day or every other day and can help manage that. I don't know if there are privacy issues or whatever, but how can we make that a little bit an extension? Is there a pilot that can be used with some of those networks to help those patients that have been identified? Just thinking aloud here.
I think that's a wonderful idea that we're not thinking, we haven't been thinking about. I think we'll start thinking about it. I think, and extension of that is the family caregivers.
Yeah.
Are we doing enough to pull them in to the care so they know what to look for? So I think that for these conditions, this needs to be a part of it. These conditions are complex. There's a recent study that just the fact that a patient has a home attendant puts them already at much higher risk for every poor outcome, for falls, for heart failure exacerbation. So I think focusing on that community is an opportunity.
Thank you.
Worth for all of us to also think about in terms of policy. We can only do the community health workers when we have value-based payments because there's no reimbursement. It's an unreimbursed service. So when they go to see the doctor, we get paid. When they go to the hospital, we get paid. When they go to the emergency room, we get paid. We do not get paid for community health workers. So that's why we drive so hard to try to get all of the contracts on a value basis rather than a fee-for-service basis, because we can't do what we think the patients need if we're fee-for-service. And we've gotten some things to value-based. Then even value-based has different levels where very few things are. I mean, in the ideal way, someone would say, "Here's the amount of money. Do your best shot at taking care of this person. Do exactly what they need." Nothing is quite like that. But some of them at least allow us, like this program, to accrue the savings. But many of our patients still are in fee-for-service arrangements, and it causes quite a lot of challenge then to be able to figure out how we're going to divert enough general fund to community health workers if there's zero reimbursement for it.
But I think, sorry.
Okay, a little confused. So is this connected to with the home care, that question that I asked when the patients are released and you said you send, home care, home attendants, is that the same?
Home care services are reimbursable,
Right,
typically if it's nursing and home health aid services. This is a group of people called community health workers who are not licensed really, and we welcome that in most cases because we want people who have been in our community, sometimes have lived experience similar to our patients who have experienced homelessness, things like that. But community health workers are really a connective tissue. They work closely with our behavioral health practices, with our primary care doctors, and they do things that you don't have to be a licensed nurse to do and things like that. So currently, we can't bill an insurance company or the Medicare program for their services.
Community health piece. Right. But the home attendants and the home care that's coming from the hospital, you could bill?
Yes.
Okay, I just need to be clear on that. Okay.
But there, the who's eligible gets very narrow. You have to have a skilled nursing need. Many of our patients have tremendous need, but it's not the skilled nursing. They need help taking their medicines. They need help getting to the doctor, or the concierge, what Feni is talking about, or what Jose is talking about. That's really what they need. And that isn't a skilled nursing need. So that's why we use peers, very successful. We think it works incredibly well. It's just, again, for us policymakers, that's what we have to push the system into, is things that enable us. And what we don't want, like, oh, we're going to start paying for each CHW visit. What we want is, let us take care of the person. Give us the amount of money and let us figure out what they actually need. And we'll put together the set of services that helps them. But our country is very far from that.
Yeah. Well, following on that, and again, I think your point is very well taken and a little bit counterintuitive, because you are trying to ensure that the patient get healthy without using the health services. And that's, how much are we using volunteers, like individuals that wanted to help out other kind of community members in terms of supporting them in, taking care of their health or managing their health care? Because all these community health workers are paid by us. But is there I don't know the legal constraints that may be there, but I can think that there are a lot of people that would like to volunteer the same way that they bring, food to people that do not have the means or something like that. Is that a possibility to expand that network or not?
It's interesting to consider. I think in a structured way through our clinical practices, it's not something I've really talked about. I mean, I think one way we've gotten at it is targeted partnerships with community-based organizations, right? And to say, you are a local community-based organization who knows how to connect people to healthy food, right? And we have contracts with you. We have our housing navigation contract we're going to talk about today. They have paid staff, but certainly the more local a community-based organization is, sometimes they have additional volunteers who can support. We have some volunteers just across our hospitals working in different things. I mean, I think from a legal perspective, access to the healthcare record, engagement in clinical services, it gets a little tricky to walk that line. But we certainly welcome volunteers in our system. We need help, and we are a community resource, and so we want to be, have community members working with us and in us and serving the community. So I think it's a great idea and something we can look at more.
And I think there is also something that we learned through COVID, because at least Health and Hospital did a massive outreach. And it will be a pity if we lose that knowledge that we have gained of the communities, the connection to the communities, getting them to vaccinate, to do testing. And if there is way economically that we can tap into that community-based organization without heavy costs to the system, particularly may be interesting to think and see, and Andy's here, all the legal ramifications, but how to empower kind of the support of our patients. Just a thought.
Okay, so I gotta move on to the next part, but I think Matt and Dr. Stevens, I think you saw the level of engagement and interest in the hospital and the work you're doing. We're very proud of all the work you're doing. You got a lot of good ideas here that we discussed to move forward. And is there any old or new business to before that?
Just one last question, and I apologize. I know we're trying to wrap up, but in the appendix, it talks us the number of actual assigned people obviously has been dwindling over time. And I'm just curious, is that related to the number of people that have straight Medicare? Is that related to the number of providers? Why are we dropping? I guess we were, just 13,000 down to 8,000.
It's partially that. I mean, I think the growth of Medicare Advantage is certainly a big, secular trend driving this. This is only for, Medicare fee-for-service patients. But the big dip in that history was the change in the attribution methodology, as Dr. Stevens went from the retrospective to the prospective model. It narrows it down a little bit more for you. So we're happy to do it. Our Medicare Advantage membership in Metro Plus and Health First is growing, and we again try to treat those patients exactly as we would have any ACO patient. But it's certainly something that policymakers in Washington are thinking.
The flip side of the change in the attribution is that the patients are actually ours, not people who pass through, but they're really people who are ours.
Since there's no further business, I declare the meeting of the HHC ACO sole member annual meeting adjourned.
Thank you.